Hello, everyone, and welcome to today's ARC Talks webinar on living well with amyloidosis. Thank you for joining us. My name is Lori Bulpett, and I'm the Manager of Healthcare and Education at the Amyloidosis Research Consortium, or ARC. This presentation was originally given to a live audience on October 26th in recognition of World Amyloidosis Day. Some technical issues, unfortunately, limited our ability to make that recording available, so we're re-recording. Thank you to our dedicated speakers for spending a bit more time with us so we can make this valuable information available to our community. Now, just a bit about ARC. ARC was founded in 2015 by Isabel Lusada, an AL amyloidosis patient, with the mission to accelerate the development of and access to new and innovative treatments for systemic amyloidoses and improve the quality of lives for patients. We work closely with patients and patient organizations, pharmaceutical companies, regulatory agencies, and researchers to drive our missions forward. Our four main areas of focus are improving the speed and accuracy of diagnosis, increasing the understanding of the science of the diseases, accelerating regulatory approval for effective treatments, and enhancing care and quality of life for patients. We are so excited for today's webinar, Living Well with Amyloidosis. We have seen an increase in the number of patients that have a difficult time managing their symptoms. Symptoms like shortness of breath, digestive issues, and neuropathy can often be the most burdensome for patients. Some patients are also unsure of when to alert their care team of new or worsening symptoms, as well as which specialists to contact. Our experts today will cover all of this important information and more. Dr. Johanna Fajardo will start the presentation off today with tips on managing your cardiac symptoms. Dr. Fajardo is the Infiltrative Cardiomyopathy Program Director at MedStar Washington Hospital Center in DC. We will then hear from Dr. Hania Ramos on managing neuropathy symptoms. Dr. Ramos is the Amyloidosis Program Coordinator at the Medical University of South Carolina in Charleston. And finally, Dr. Monica Nandwani will cover gastrointestinal symptoms and management. Dr. Nandwani is the Manager of Advanced Practice Providers at Stanford. Our speakers will then take questions from the audience that we received on October 26th. And that question and answer session will be moderated by our Executive Director of Strategic Partnerships, Vanessa Boulanger. So Joanna, whenever you're ready.
Thanks, Lori, for such a generous introductions. All right, so those are my disclosures. I have participated in the advisory boards for Pfizer, Alnylam, or Eidos, which are pharmaceutical companies that work with amyloidosis. So let's start by giving a brief overview of what cardiac amyloidosis is. Amyloid is basically a protein that accumulates in certain organs. It's basically produced by either the bone marrow in AL patients or the liver in ATTR patients, and it travels through the blood and accumulates in organs like the heart. It was mostly diagnosed during autopsy just 20 years ago, but given recent advancements in technology, we can now diagnose it quickly and effectively. The nomenclature, just to give an explanation, the A stands for amyloid, and is followed by the type of amyloidosis, either transthyretin by TTR or L for light chain disease. Again, this is the different types of cardiac amyloidosis. There's about 5 different types of amyloidosis that affect the heart, but we're going to concentrate on primarily 2 types. The first one is AL amyloidosis. Again, the amyloid is produced in the bone marrow. It is mostly diagnosed by cardiac biopsy, which is the gold standard, and is treated by chemo plus or minus stem cell transplant and supportive management. Transthyretin amyloid is produced by the liver and is different. It could be diagnosed either by a nuclear scan, T99 PYP scan, or cardiac biopsy. But most importantly, patients have to undergo genetic testing to further classify it as hereditary if we can find a mutation, or a wild type if there is no variant identified. This is treated by different medications that are novel treatments over the last 5 years and include gene silencers, TTR tetramer stabilizers, and in some cases, we recommend heart and liver transplants. Again, AL, just a brief review. So the bone marrow produces the antibodies, which we call heavy and light chains, and they become malignant. And this excess of light chains or antibodies misfold and become amyloidotic, which again travel through the bloodstream and deposit in different organs like the heart or the kidneys. And this is a brief overview again of the diagram where the amyloid is produced by the bone marrow, and then the amyloid fibers accumulate in different organs. In ATTR, the pathophysiology is actually different. It's actually transthyretin is a protein normally produced by the liver, and it's used to transport thyroxine, which is the thyroid hormone, and retinol, which is normally called vitamin A. It circulates in homotetramer, which is 4 pieces waved together, and sometimes it breaks apart into single monometic pieces. This misfolds and again accumulates in different organs, including the heart or the nerves. It is hereditary if a pathologic mutation is the cause of the amyloidosis, or if we cannot find a variant, a genetic variant through genetic testing, we call it wild type. And we at this time don't know exactly why this is happening. And this is again a diagram where the tetramer, the TTR tetramer, is nicely produced by the liver, but at some point, either by the mutation or by an unknown factor, it separates into monomers and it becomes amyloidotic and again accumulates in the nerves or the heart. So what are some red flags, signs and symptoms? As patients, you probably already know that you presented with either shortness of breath, dizziness, carpal tunnel syndrome, renal failure or protein in the urine, nausea, vomiting, diarrhea, sometimes a combination of all of them, nerve pain, and on occasion, even eye problems such as glaucoma or dark floaters. Today, we're gonna focus my talk on, cardiac amyloidosis, and basically amyloidosis affects in 2 ways the heart, either creating pump failure or arrhythmias. And we'll walk through each of these symptoms. So we'll start with managing pump failure. So once the heart is invaded by the amyloid, it becomes stiff and it's difficult for the heart to actually pump. So what can we do about it? Well, there are some medications that we can use, like milveridone or dopamine. They're called inotropic support, and they're given to help the heart pump better. These are given by a V continuous infusion, and they're reserved for like severe failure. So these are patients that come in, these are used for patients that come in on severe shock, and we have to help them temporarily with these medications for the heart to pump. Sometimes, if the heart does not recover, we can send the patients with these medications through an IV continuous infusion, but knowing that this is only for palliation of symptoms, meaning it will be through the trajectory, through a destination where the patient has less symptoms, but knows that there is that is not cured, that the disease will progress. Other heart failure medications, such as ACE inhibitors, angiotensin, or ARBs, beta blockers, they usually work in different types of heart failure, but they are not routinely tolerated by amyloidosis patients, nor have they shown any benefit on the amyloidotic hearts. So we should not be putting those medications or adding those medications to the therapies. In fact, some of these medications create or cause low blood pressure, and some patients that started on taking those medications, they have to stop taking them to avoid the low blood pressures. And sometimes the blood pressure is so low that we have to add medications to actually raise the blood pressure. So because the heart is not pumping well, we're gonna have some what we call fluid overload symptoms. So all the fluid that a heart is unable to pump throughout the rest of the body comes back and makes you shorter breath, invading the lungs, or sometimes it gives you nausea, vomiting, diarrhea, or inability to eat properly because the belly feels so full because that fluid is concentrated in the liver area. Or sometimes it goes to the feet, creating feet swelling, ankles, or lower leg swelling. Other symptoms include coughing because of the fluid in the lungs, and rapid increase in body weight. So how do we manage that? Well, we teach our patients to check their weight daily, because if you gain more than 2 pounds in 24 hours, that's more than likely fluid that has to be taken out as soon as we can. Therapies to do that include the water pills, which we call diuretics, but other things include pressure stockings to help promote the venous return so that the fluid can be diuresed out of the body. Leg swelling to again promote that venous return. Other tips and tricks that my patients tell me is taking the diuretics and laying down to help the diuresis of these fluids. Decreasing the fluid intake, which I'll talk about more in further slides. At this time, we recommend 2 liters of 64 ounces, or reducing the sodium intake to 2 grams or 2,000 milligrams a day. So we'll talk about diet. So you should always ask your healthcare professional about how much fluid you're allowed to drink, but usually it's about 1.5 to 2 liters or 6 to 8 cups a day. We have to remember that fluid is anything liquid at room temperature. So water, tea, coffee, ice cream, jello, ice, soups, all those things, even some fruits count towards your fluid restriction. It's hard to do though, but a few things that I can tell you is you can suck on sugarless hard candies or mints. You can purchase a small glass so you can trick your brain so that you're drinking more, but not really. You can suck on frozen fruit like grapes or blueberries. You can chew gum. You can try to take your medications with pudding or yogurt or applesauce to avoid the liquids. You should also avoid ice in your drinks because that's extra fluid that you're not really counting. You can also use a humidifier to moisten the air and will help you with control your dry mouth feeling. And you can always sip slowly and enjoy your fluid intake throughout the day so that you don't go over your restriction. But how about sodium? Well, routinely we recommend, like I said, 2 grams of sodium or 2,000 milligrams of sodium a day or less for patients that have heart or liver or kidney disease. And then this is especially for patients that say, I just add a little bit of salt, but actually a teaspoon of salt is over your sodium limit, which is 2,300 milligrams of sodium. We need to remember that salt is an acquired taste. So we have to retrain our papillary taste buds to actually go back and start enjoying food without it. We recommend that patients try to choose food items that are within the 200 milligrams sodium per serving to keep your track of your sodium. Another way to teach it is to remember it is actually to try to keep 500 milligrams of sodium per meal. That would be 3 meals, and then leave another 500 for snacks in between. So nowadays, there's a lot of food that are labeled as low sodium, but actually even the low sodium foods may still contain too much sodium. So we need to be aware of processed meats, processed cheeses, bouillon, fast food, pickles or olives. Even if they are labeled as low sodium, they probably have too much sodium, and you have to read your label as well. So in that sense, we need to, I'll show you, the comparison between the 2 food labels. So ideally, we try to choose the low sodium choice, but we still have to be aware, like in this label, is about 430 milligrams per serving. So that's one of the tricks that you have to be aware that if you, what's the serving size? Because if you eat more than 1 serving size, then you have to double the amount of sodium. So just be careful with that. So what about preventing the unintended weight loss? Well, the heart is working overtime because of pump failure and will eat most of the calories that you eat. So if you're struggling with unintended weight loss, you need to try to increase your calories as follows. You can eat hard-boiled eggs or a snack, or add them to salads or sandwiches to increase your protein intake. You can also add grated lower sodium cheeses to salads, or cooked vegetables or pasta. You can enhance your recipes by adding dry milk or powder or to sauces, gravies, and casseroles to again increase the content of protein without increasing the number of sodium content that the food has. Using unsalted peanut butter is a great snack that again is high in protein but lower in sodium. And also try to do other things that promote your appetite, including gentle exercise like walking, so that you can stimulate your appetite and help you prevent muscle loss. Other symptoms that pump failure causes includes fatigue. And this is either for just the disease in itself, or sometimes the treatment such as chemotherapy. So tips to manage the fatigue at home include avoiding the overexertion. So you need to try to pace yourself throughout the day, because if you burn yourself out one day, you're gonna have to pay for it the entire week. You should combine low energy hobbies with high energy activities, and ask other people to help you with tasks like cooking, shopping, housework, so that you can save your energy for the next treatment or just for the next activity that you want to do. You need to listen to your body and just eat when you can, and sleep when you can, and do things when you can. Try to eat frequently, at least 5 to 6 times a day. It's incredibly, for people that struggle with fatigue, it really takes a lot of them to eat big meals. So just eat smaller meals and a snack if you can. On the days that you do have the energy, you should try to cook larger portions, of food, so that it's ready for you to go, and you don't have to cook every single day. And again, include your protein and your fat in each meal. Other tips for shortness of breath. Well, it could also be for just, like we said, fluid overload, which we already know that we have to treat with diuretics and fluid and sodium restrictions, but it can also be caused by pump failure. So other tips and tricks include the use of fans when feeling short of breath. That's again to trick your brain that you're having more air going through your lungs. You can elevate the head of the bed. You can use breathing techniques or Tai Chi, which has shown that has improved, the relaxation, and it's improved manages your breathing so that you don't have to be so short of breath. The other way that amyloid can affect the heart includes heart arrhythmias. And the number one thing that we all have to do is to monitor for signs and symptoms. So those include dizziness, palpitations, feeling of passing out, fainting, fatigue with exertion. Other things that you have to try to avoid is dehydration or electrolyte imbalance. And that's obviously by drinking enough fluids, but not going over your fluid restriction, but also taking your medications as directed. So make sure you take your diuretics, your potassium and magnesium supplementation. That's one of the things that I teach to my patients. These are not vitamins. These are actually electrolytes that will affect your heart function. So please take them correctly. The other thing is, when we have identified the arrhythmia, we have to treat it. And not all abnormal rhythms grant treatment. And it will depend based on, with the arrhythmia that you have. So some of the medical therapies that we offer, sometimes we have to put patients on medication that slow the heart rates if they're going too fast. Or in some cases, when the heart rates are too low, we actually have to put pacemakers on. Other medical therapies that we include is anticoagulation to prevent blood clots. So again, device therapies, like I was speaking before, a lot of the times when patients are diagnosed with amyloidosis, we ask them to wear monitors to evaluate if there's an arrhythmia present. And once we identify it, we can, if it's too low, the heart rate is too slow, we actually have to place pacemakers if it's appropriate. And in some patients, actually, we even place internal cardiac defibrillators to shock you and out of the rhythm if needed. So in conclusion, regardless of the type of amyloidosis, it is possible to manage your cardiac symptoms. And there are different modalities, including, device therapies, diet, sleep, exercise. We have to pay attention to all of those that, the important role that all of those factors play in the management of cardiac symptoms. And, this is a team effort. Patients and families should work with the providers to find ways to live better, no matter what your symptoms are. So thank you so much for giving me the opportunity to speak to all of you today. You guys are our superheroes, and we are here to support you always. Thank you.
Wonderful. Thank you so much for that incredible information. Lots of great tips in there. And I will now hand it over to Dr. Ramos, the Amyloidosis Program Coordinator with the Medical University of South Carolina, to cover neuropathy symptoms and management.
Thank you, Laurie, for the introduction. So yes, I'm the program coordinator for the Medical University of South Carolina, and not only do I work in coordinating with the center, but I also help with some of the cardiology clinical trials, specifically for TTR, for transthyretin cardiomyopathy, along with Dr. Daniel Judge. So I have no disclosures to make. And my learning objectives today with you is to understand how clinicians manage neuropathic symptoms while on therapy, when to seek care, the role of interactions between the amyloidosis centers and the physician or the care team, and the health and wellness tips. So a little bit about the history of the familial amyloidosis and neuropathy. It was first described in 1952 among the patients in Portugal. And later on, it was discovered in South America, specifically in Brazil, and in Sweden and Japan. Now, there are over 140 different TTR gene mutations, and it doesn't mean necessarily that everyone or every gene mutation will present or manifest with a symptom. However, you can find always more information about the specific variation or the classification of what you're looking for. Let's say if you had the hereditary ATTR, you can go to this site and they'll give you specific information with the ethnic origin and the protein variant. Moving on with the most common pathogenic variants, the first one is the V30M, and that is seen worldwide. I can say that all of them are seen everywhere, but this is where it's more associated. The V122I, that's more in the Afro-American, Afro-Caribbean population, about 3.4%, and it's mostly seen here in the US. The last one is the T60A, and that one is more associated with Ireland, Germany, and the Appalachian region in Australia. I do want to mention that, for example, the B122I, it has an association more with the cardiomyopathy symptoms versus the V30. It's at an earlier stage, an earlier age that you can identify this, more associated with the neuropathic pain. The T60 can have a variation between the neuropathic and cardiology or cardiac symptoms. So what is neuropathy? Neuropathy means a disease that is of the nerve injury, and it's irreversible injury. What do I mean by this? What I mean is that once the nerve is damaged completely, it's irreparable. There's no way to reverse it back. However, that's the main goal and the point of this care is to diagnose it at an earlier stage, and that way you can get medication and treatment. But I'll explain a little bit further. The amyloid plaque, what it does is it accumulates or it deposits in parts of the nervous system. And some of the examples that we can see are in the peripheral nerves. We can have it in the autonomic nervous system and the spinal cord. What do I mean by autonomic nervous system? That is what is the fight or flight response. So when you start exercising and your heart rate increases, then that is just part of it. You start sweating. That's just part of your autonomic nervous system. So for example, for amyloidosis patients, there are occasions where the orthostatic hypotension, meaning they have a sudden drop in blood pressure, then that could be some of the symptoms associated with that Joanna spoke about. Typically, it occurs distally, then it works its way up towards the trunk in the extremities. So it starts in the lower extremities and then it goes up towards your upper extremities. It is said that the worsening or the prognosis worsens if it's in the upper extremities. Now you'll find that some of the patients may have on one side and then eventually it's on both sides. You will always see bilateral mostly, but nonetheless, there are the patients that have on one side and then eventually it goes to the other side. And this is for any kind of neuropathy, diabetic neuropathy, drug-induced neuropathy, or amyloidosis-based neuropathy. The treatment and management will have some of the symptoms that were already spoken about, but just some of that pain, the tingling and numbing, they call it the pins and needles sensation, paresthesia. So you'll have that altered sensation. And like I mentioned earlier, with the orthostatic hypotension and some of the abnormal heart rhythms are some of the symptoms that we can see in patients. And that can be with the TTR or the AL amyloidosis or any of the other amyloid. We're focusing more towards the TTR and AL based. They can have some of the unsteadiness and dizziness. They can have some of that gait or unbalance. So all of these symptoms are very important to keep in mind when you're with your physician. If you see or feel there's something where you have to see a neurologist, maybe you've seen the cardiologist and haven't seen a neurologist, then it would be a good time to talk about it and ask for a referral to have this treated or evaluated as well. The workup, it's a process, and they have some of the common ones with the independent surveys, including the Norfolk quality of life diabetic neuropathy. So they have a scoring system. The nerve conduction studies and electromyography, if you see from the picture, you can see that this is kind of like a way to detect or determine the wavelength of how the nerves are working. So from one point to the next, is there still some sensory there? How, can you feel on a certain specific point where they touch? And so that's what they based it off. Then we have some of the other workup that they can do, orthostatic vital signs, the autonomic function testing, and forgive me, it should be SUDO with SUDO, motor accident reflex testing, which is also just part of the autonomic nervous system and how they test it, and pseudo for sweat, right? So that would be part of their testing. They can also do the nerve or skin biopsy, although they are a little more careful about that because you can damage the nerve. Like Joanna mentioned, the biopsy is the gold standard, and definitely heart biopsy and any other kind of biopsies, bone marrow biopsy, fat pad biopsy, but of course the higher sensitivity and specificity would be more based on heart. For treatment, we have the TTR stabilizer, and that just what it means. It stabilizes that abnormal protein that's accumulating in your heart or depositing. We have tafamidis, which is the only FDA approved. There are another clinical trial in place with AG10, but that's not FDA approved yet. We have diflunisal, which is also something that physician, your specialist, will decide whether to treat you with. And the most standard will always be the tafamidis for now. Then for the TTR silencers, we have the FDA approved for only hereditary TTR right now. This is the inotersen and the patisiran. We also have for the AL amyloidosis type, we have the daratumumab, which not long ago it was approved and FDA approved. And the hematologist or oncologist will treat it along with chemotherapy. So this could be the CyBR-D regimen that they include. And of course, some of the symptomatic therapies. So I'll just go a little bit over this, meaning for the orthostatic hypotension and autonomic dysregulation, they'll have the first line treatment, which for hypertension on that occasion would be hydralazine, for example, or for hypotension, which is low blood pressure, then that would be more of the midodrine in order to increase some of that heart rate, as long as some of the other medications that you're seeing. For the pain and paresthesia, that the first line treatment will be gabapentin or pregabalin. There's also duloxetine and lidocaine. Sometimes what they'll do is they can compound or form a based topical medication for you on a case-by-case for a patient. Again, depending on the damage and severity of the nerve and how it's been affected, they might be able to compound or do something for it. You know, and again, it depends on how long or the relief is, but the nerve will continue. You'll still have some of that sensation. We do try to avoid the TCAs due to its cardiac effects. Now, I'll leave this for the next speaker, but for right now, I just want to focus a little bit on the physical and occupational therapy. It is very important to continue doing a treatment-based plan, if possible, with your clinician or your center. Sometimes they base it specifically to what you need and what is recommended. Cardiac rehabilitation is always great to have physical therapy and occupational. I can't emphasize how important it is to keep that momentum, that muscle working, your body just a continuous. And it's, of course, day by day. There'll be some bad days, some good days, but the important thing is to continue. You know your own body, and you know, sometimes you might want that opinion where if you don't feel comfortable at a specific center and you want an additional opinion at another specialty center, you can always do that. Or if you feel comfortable and you still have questions, always ask your physician or your clinician or your APP, anybody who's in your care team, please ask questions. The supplement, I did skip over, but the health and wellness, like I mentioned, it's so important. Sometimes it's recommended now that it's not just the cardio, but also doing a resistance training as well. A combination of that will prevent your muscle from wasting, and just having that strength and continuation for motor strength and you know, preventing that worsening. So when to seek care, the important parts of the red flags are, if you have a history of TTR gene mutation, it's so important. I can emphasize that you should get tested, or if you've been tested and you have a family member, a first relative, there's a 50% chance that a family member, first relative, might get it. So for example, if you have it and you have a bloodline, your daughter, your son, so, or did it come from your grandparents? Did it come from the paternal side, the maternal? So all of that is very important and will determine and help with those red flags at a sooner time. The average patient has 4 to 5 specialists before they're actually diagnosed with the correct diagnosis of amyloidosis. The workup, like I mentioned, it could be caused by drug induced, or it can be based from diabetic neuropathy or from a history of diabetes. So all of them have to be ruled out beforehand. And those can be some of the common causes of neuropathy, which again, I can't emphasize how important it is to do or to be referred to someone if you have not seen a neurologist and you're having this sensation or this pain or tingling, pins and needle. You always have the freedom to request a second opinion, like I mentioned. And at the end of the day, the amyloidosis centers, they act as an extension of your continuation in care. Although some centers do focus completely on their treatment and everything, you don't have to go to somewhere else, but maybe your location, it's not close to one of the centers and it's a long drive, or maybe you have to fly to a location. So sometimes, you know, just having that continuation with who you see, your physician, your APP, your clinician, that's the best method to just continue with both. And then, like I said, you're your best advocate. You know yourself. I want to thank the Amyloidosis Research Consortium for letting me be part of this presentation. And we are basing this on World Amyloidosis Day. So this is for y'all. Thank you so much. And I'll throw the baton.
Thank you so much, Dr. Ramos. That was wonderful. I'm so glad we re-recorded this because a lot of really good information, and there was, I think, a little bit interrupted in the original presentation. So thank you so much for coming back and explaining that so well.
Thank you.
And especially stressing the importance of the multidisciplinary care. So now we will hear from Dr. Monica Nandwani from Stanford University on managing gastrointestinal symptoms.
Hello, everyone. Again, my name is Monica Nandwani, and I will be discussing gastrointestinal or GI amyloidosis. So some topics to cover as part of this presentation include the different patterns of GI amyloid involvement in the luminal digestive tract, so the esophagus, the stomach, the small bowel, and the colon, some symptoms associated with digestive involvement of amyloidosis, diagnostic testing, treatment options, as well as background about epidemiology and data regarding variants. So let's start off by talking about patterns of gastrointestinal amyloid involvement. And Dr. Fajardo and Dr. Ramos did a great job reviewing, giving the background about amyloidosis. So this occurs when there is an abnormal protein or amyloid builds up in organs that interferes with normal functioning. As discussed, it can affect various organs, including the digestive tract, causing a variety of symptoms. And we heard about the different major forms of amyloidosis. So as far as GI amyloid involvement, amyloid can deposit anywhere in the digestive tract or the nerves that regulate it. So for luminal digestive patterns, this can include infiltration of the mucosa, and the mucosa is the lining of the digestive tract. It can infiltrate the muscle, it can affect the nerves and cause neuropathy, which we just heard a lot about, and can also affect the blood vessels to the digestive tract, so vascular involvement. So let's break it down based on the level of involvement. So with mucosal involvement, so the mucosa is the site of absorption of when we digest food, of waste products. And when there is mucosal involvement in amyloidosis, symptoms that can occur include diarrhea or malabsorption from decreased absorption of those nutrients. And diagnosis of mucosal involvement is usually done during endoscopy, so either upper endoscopy or colonoscopy, and biopsies have to be obtained with special staining, and we'll be talking about that in a few slides. For muscular infiltration, so the muscle really helps with the contraction, or what we call the peristalsis, throughout the digestive tract, as well as the motility or the movement throughout the digestive tract. When there is muscular infiltration in amyloidosis, this can produce symptoms that decrease the motility of the digestive tract and cause what we call stasis, or kind of just stagnation in the digestive tract. This can cause symptoms of diarrhea or malabsorption, which can be seen in a condition known as small intestinal bacterial overgrowth, or SIBO. So SIBO occurs when there is an abnormal increase in the overall bacterial population in the small intestine. So when there is slow passage of food and waste products throughout the digestive tract, this creates a breeding ground for bacteria, and that excess bacteria can cause symptoms of diarrhea, malabsorption, and weight loss. Other symptoms of decreased contraction or motility can also include constipation, pseudo-obstruction, which means mimicking an obstruction. So there's not an actual obstruction, but because things are so slow to move, you have symptoms mimicking an obstruction, such as nausea, vomiting, or abdominal pain. And diagnosis can be made through a variety of imaging studies, transit studies, or manometry, and we'll talk about these diagnostic tests in a few upcoming slides as well. For neuropathy, and Dr. Ramos did an excellent review of this, but neuropathy can affect coordination of gastrointestinal motility or movement throughout the gut. So some symptoms of this motility that we discussed can include nausea, vomiting, abdominal pain, diarrhea or constipation. If there's neuropathy, that can also affect sensation to the gut and sometimes can actually cause increased sensation or increased sensitivity. Diagnosis can be done through manometry or various transit studies. When there is vascular involvement, the blood vessels are affected, and this can affect the delivery of blood to the gut. And symptoms of vascular involvement can include ischemia, which is tissue death, or GI bleeding from ulcers, and symptoms can include pain and diarrhea. And diagnosis of vascular involvement can be done during upper endoscopy or colonoscopy, depending on the site of bleeding. So let's talk about some GI symptoms associated with amyloidosis from the proximal, so the top of the digestive tract, to the bottom of the digestive tract. So starting with the esophagus, some symptoms that can present include gastroesophageal reflux disease or GERD, dysphagia or difficulty swallowing, so feeling like food is getting stuck or slow to pass the food pipe or the esophagus, food impaction, so food getting acutely stuck in the esophagus. Symptoms that affect the stomach can include abdominal pain, nausea, vomiting or bloating or distension. Symptoms of small intestinal involvement can include diarrhea, malabsorption, weight loss, or again, pseudo-obstruction, where there's not an actual obstruction, but because of the slow movement throughout the gut, it can produce symptoms mimicking an obstruction or a blockage. And colonic symptoms can include diarrhea, constipation, or fecal incontinence. So one thing I did want to mention about digestive symptoms is that most symptoms in amyloidosis are nonspecific and can also be seen outside of amyloid. So for reference, for example, for reflux or gastroesophageal reflux disease or GERD, it's estimated that about 1 in 5 or 20% of adults experience GERD symptoms at least once a week, if not more. For dysphagia or difficulty swallowing, it's about 4% of adults. For functional dyspepsia or indigestion, it's estimated that 20 to 30% of the adult general population can experience these symptoms. For irritable bowel syndrome, it's up to 13% of adults. For constipation, about 15%. And for fecal incontinence, it's about 6% of adults. So just something to keep in mind that these are common symptoms that are seen in the general population as well. Another thing to keep in mind is that it's important to consider other gastrointestinal conditions as part of the differential diagnosis or potential cause for these symptoms. So some other conditions to consider include inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, celiac disease, which is an allergy to gluten, eosinophilic esophagitis, which is kind of an allergic disorder of the esophagus that can cause symptoms of difficulty swallowing. And of course, if there are any alarm symptoms, you want to make sure that you are evaluating or suspicious of a potential underlying cancer. So alarm symptoms to be wary of include new onset, difficulty swallowing, pain with swallowing, if there's any evidence of gastrointestinal bleeding, so if you're vomiting blood, if there's bright red blood in the stool, or if there's dark or tarry stools, if there's unintentional weight loss, if there's a family history of gastrointestinal cancer in a first-degree relative, these are some alarm symptoms that you want to make sure you discuss with your clinician. Additionally, it's really important to consider medication side effects. So GI symptoms are a common side effect for many medications, and there are a lot of individuals who take multiple medications. So it's estimated that more than 80% of people who take 5 or more medications will have at least one side effect. So if you notice that you're starting to have new symptoms, keep in mind and try to think, did you recently start a new medication that could be causing side effects? So let's talk a little bit more about diagnostic testing. So upper endoscopy and colonoscopy are usually the first tests performed to diagnose or evaluate any digestive symptoms. The benefit of these tests are they allow the ability to obtain biopsies. So the presence of amyloid fibrils can be confirmed during biopsy with special staining called Congo red staining. Additionally, endoscopy allows for treatment. So if there's concern for bleeding, bleeding control can be done during these procedures. Or for example, if someone is having trouble swallowing and there's an area of narrowing in the esophagus, stretching of the esophagus can be done during endoscopy. One thing to keep in mind is that in amyloid, sometimes findings can be nonspecific, and it's therefore really important to get those biopsies and to do the special staining. Common areas that are biopsied include the rectum, as it's easily accessible, but it's thought that the highest yield in the digestive tract is the duodenum, which is the first part of the small intestine. Other diagnostic tests to consider include imaging studies such as a CT scan, MRI, or barium studies. Motility studies that can assess transit or movement throughout the gut can include scintigraphy, or sometimes what we call a gastric emptying study. There are also whole gut transit studies. There's manometry. So this picture is actually a picture of me. I'm the patient in this picture undergoing a test that we call esophageal manometry, which looks at the peristalsis, or the squeeze in the esophagus. So it looks at how the esophagus is pushing food down the food pipe. Other motility studies include the wireless motility capsule, which looks at whole gut transit. And there's a study called a SITS marker study that looks at colonic transit, or emptying in the colon. And then, of course, there are a variety of different breath tests. So there's a breath test that can look at lactose intolerance, fructose intolerance, and there's also breath testing that can look at the condition that we discussed earlier known as small intestinal bacterial overgrowth. If you want to learn more about high-resolution esophageal manometry, we created a patient education video called What to Expect for Your Esophageal Manometry Procedure, and you can find that online on YouTube. So now that we've talked about diagnostic options, let's talk about treatment options. So starting with GERD, some treatment options include dietary modification, and I will caveat this by saying that you will notice that most of the treatment options start with dietary modification as one of the options. Other treatment options for GERD include acid reduction, whether that's with antacids, histamine receptor blockers, or proton pump inhibitors, also known as PPIs. So these can be obtained either over the counter or via prescription. And for GERD, there's also options for endoscopic or surgical treatment options in those carefully selected individuals. For dysphagia or difficulty swallowing, treatment options can include dietary modification, dilation or dilatation or stretching, and Botox when appropriate. For the stomach, treatment options for stomach symptoms such as nausea, vomiting, early satiety, or feeling full after eating a small amount of food, treatment options can include dietary modification, so eating smaller, more frequent meals rather than 3 large meals, avoiding fatty foods which are more difficult to digest, avoiding lying down 2 to 3 hours after eating. Those are some of the dietary modifications that can be made. There are medications known as prokinetics, which can speed up the emptying of the stomach. There are medications to help stomach expansion. So there are some over-the-counter options as well as prescription options. Dr. Ramos talked about various neuromodulators that can help with managed pain or neuropathy. There are antiemetics or anti-nausea or anti-vomiting medications that are available, and there are also endoscopic treatment options. For small bowel symptoms, again, dietary modification can be, it should be explored. So some people will have a lot of bloating or gassiness, so focusing on low gas foods. Prokinetics, again, medications that can speed up the gut. For individuals who are suspected or diagnosed with small intestinal bacterial overgrowth or SIBO, there are a variety of antibiotics that can be prescribed to treat this condition. There have been case reports in individuals with severe diarrhea who have responded to octreotide, which is an injectable medication. There are bile salt binding agents that are prescription that can help with diarrhea. There are over-the-counter antidiarrheals as well as prescription antidiarrheal medications. And in rare, severe cases of weight loss, inability to tolerate oral intake, and severe diarrhea, parenteral or IV nutrition can be considered. For colon symptoms, again, dietary modification, prokinetics or medications to speed up the gut, and there are over-the-counter laxatives as well as prescription laxative options. So now that we've talked about treatment options, let's review data regarding some of the variants. So there was a retrospective review of over 2,000 patients with amyloidosis in a tertiary referral center, and this paper was published back in 2013. Of these 2,334 patients, 76 or 3.2% had biopsy-proven amyloid involvement of the GI tract. So of this 3.2%, the median age was 61 years old. 21% or 16 of the 76 patients had amyloidosis localized to the digestive tract. And for these individuals in this tertiary referral center, supportive care was the mainstay of treatment, and none received anti-plasma cell therapy. Systemic amyloidosis with dominant GI involvement was present in 79% or 60 of these patients. And of these, so 50 of the 60 or 83% had AL amyloid. And 45 of the 50 were treated with anti-plasma cell therapy. So in this retrospective review, the most frequent digestive symptoms in order of frequency were weight loss in 45% of patients, followed by GI bleeding, heartburn, early satiety, diarrhea, and abdominal pain. As far as data regarding variants, the data is extremely limited, but a report from the Transthyretin Amyloidosis Outcomes Survey suggested that GI manifestations are common. Survey data from over 1,500 hereditary TTR amyloidosis and 160 wild type were analyzed. And in those with hereditary amyloid, 63% had GI symptoms versus 15% with GI symptoms in wild type. The most common symptoms in this group were unintentional weight loss, early satiety, and alternating diarrhea and constipation. And the GI symptoms were more common with a V30M mutation versus other mutations and seemed to be more common in younger onset patients less than 50. One thing I did want to mention is that the authors of the study noted that for patients with predominantly cardiac complications in wild type, the authors estimated that, and this is a direct quote, the prevalence of gastrointestinal manifestations was not evidently higher than expected in the general population. And you can see on the table the distribution of GI symptoms in patients with ATTR amyloidosis. And so in conclusion, amyloid can cause symptoms by either direct deposition in the various layers of the digestive tract or by nerve involvement. Only the mucosa can really be evaluated by endoscopic biopsy, so the absence of amyloid on biopsy does not exclude amyloid involvement. Involvement appears to be common in familial amyloidosis, and diagnostic options and treatment options exist and can be customized to specific symptoms. So with that said, I want to thank you all for your time and attention. I want to thank ARC for this invitation to present, and I want to thank my fellow panelists for their excellent presentations, and I look forward to any questions. Thank you.
Thank you so much. That was so informative. I think there's, clearly a lot of symptoms that patients can experience, but thankfully there are quite a few treatment options for each. So that is the good news. And I think a lot of patients will, hopefully go and seek some help from a specialist. So thank you very much. We received quite a few questions from our live presentation, but there were some common themes. So we tried to kind of condense due to time constraints. So we'll have about 15 minutes of questions, and we picked out some of the more common and frequently asked questions. So I would like to hand it over to Vanessa Boulanger, ARC's Executive Director of Strategic Partnerships, to moderate. Thank you.
Thanks so much, Lori, and thank you all for your excellent presentations. This was really great. So we do have a number of questions that came in, and I think that I'll just try to point out who should answer, but certainly feel free to respond if you have something to add. So this, I think, should go probably to everyone, but maybe we'll start with Dr. Fajardo. I feel like my doctor isn't addressing my symptoms and I'm continuing to decline. What is the best way to go about getting a second opinion?
Thanks. I'm sorry about that situation. That's difficult to go through. I would say, speak to your provider and see if there is anybody else in the team that can take care of symptom management. But if not, there's ARC has a wonderful website that can provide some resources, as well as the amyloidosis support group, where you can find an amyloidosis center that is local or within your area, where you can perhaps reach out and see how you can get reevaluated. I don't know if anybody else has any other suggestions, but in my experience, everybody working on amyloidosis really just wants to help. So we all know each other and we'll be happy to, just share information and share resources to take good care of our patients.
Great, thank you so much. And then maybe a question for Dr. Ramos. I've been told by my doctors that I might always have neuropathy. I'm currently taking medications that help, but am I destined to always have neuropathy?
That's a good question. So based on the presentation and what we spoke about earlier, it depends on the cause. It's unfortunately a permanent process. The nerves are capable of healing if their protective insulation has been damaged. But if it's the actual nerve cell, then that's when the problem is, and it just it eventually dies. So we want to prevent that, and we want to treat it. It's nothing to discourage, contrary, it's just to let you know something, everything, how the sensory neuropathy and how all of the nerves work within itself and in its cell. I think the medications is the best way to address it. Continuing with medications, if something doesn't work, then maybe you can try something else. For the motor, I would say involvement is more challenging, and that is just with physical therapy. Physical therapy, occupational therapy, I support it. Yes, continue doing that, and that will be very helpful.
Great, and I'm going to keep you on the spot. This is another neuropathy related question. So is it possible for amyloidosis related neuropathy symptoms to present on only one side of the body?
So the amyloid neuropathy is a length dependent. So it starts from far away and then it starts moving up towards the trunk. It is a mixed sensory and motor. Again, most of the patients will experience first sensory, and then eventually with time, as it worsens, as it increases and the prognosis worsens, then that's when the motor is involved. But again, I would say that not even just for amyloidosis, I would say for drug-induced, for diabetic neuropathy, usually everything, it runs on bilateral, it goes on both sides and then eventually moves up.
Sorry. Okay, great. Thank you. Let's see. Maybe this one for Dr. Nanvani. There are very few gastroenterologists seem to know how to treat amyloidosis symptoms. How can we find treatment, and do the treatments affect the digestive system?
That's a great question. So as we discussed earlier, many of the symptoms seen in amyloid can actually also be seen outside of amyloid, including dyspepsia or indigestion, reflux, constipation, or diarrhea. And generally, gastroenterologists and gastroenterology providers are pretty well versed in managing these symptoms. So I would really recommend describing the symptoms that you're experiencing to a gastroenterologist or gastroenterology provider if you have not seen a specialist yet, and really summarizing what has worked and what hasn't worked for you in the past. You know, as Dr. Ramos mentioned, you are your best advocate. And if you still feel like your symptoms are not managed well, then it is worthwhile seeking a second opinion, perhaps in someone who is more subspecialized or someone who might be more knowledgeable about amyloidosis. And I can say that oftentimes everybody really wants to work together as a team and support the patient and make sure you're doing well. So if it's something that you feel like you've exhausted a lot of options and are not feeling better, I think it's very reasonable to seek a second opinion as well.
Great, thank you. Sorry, I just had a internet freeze for a moment. Thank you for that. All right, so maybe Dr. Fajardo, what are the heart failure drugs that are poorly tolerated in amyloidosis patients, and are there alternatives?
Yes, thank you. That's a great question. So heart failure medications include the ACE inhibitors, the ARBs, calcium channel blockers, beta blockers. Those are routinely medications that are used for what we call dilated cardiomyopathy, where the ventricle is very large, and they help with the pumping function of the heart. However, if you recall from our presentation, when the amyloid involves the heart, the ventricle is small and stiff, and that's why they do not work. So they're not only poorly tolerated, but they actually are not helpful in the management of heart failure, and they should be avoided. On occasion, when the patient has an arrhythmia, like a very fast arrhythmia, we can trial some beta blockers, but eventually, as the disease progresses, we don't need them anymore, and we try to pull them off just to avoid any hypotension. In general, there is no alternatives because, again, there is no medication that has function, that has proven to be helpful in the pumping of the heart.
Great, thank you so much. I think this may be the last question. I'll pose it to all of you, but maybe we'll start with Dr. Nandwani. Having HATTR, so hereditary ATTR, at what age should I tell my children and talk to them about genetic testing?
Maybe I will defer that to Dr. Ramos first, since she's the expert in that field.
Sure.
I'll throw my grain of salt, and then Joanna can tell a little bit of what she thinks. But I think the moment you find out about your diagnosis, and of course, there's some people that want to keep it private, and that's always respected if you want to do that decision, but eventually tell your children. That's one alternative. The other way is that many times the genetic counselors or the amyloid center, what they'll do is they'll provide a letter and the variant specific for what you're diagnosed. They'll have it in hand. So this is for the family, so they can review it, so they can read it, and if they want to be tested, there are programs available where they can be tested for free, and this is always an option, a good option to have for the children to have, of course, if they want to get tested, and that's their decision to make, but the sooner the better. Absolutely.
So I'm going to chime in. So it really depends on what the amyloid has affected. So in the case of cardiac amyloidosis, the guidelines say that we should start screening children in about teenage years, especially if they're going to be playing sports. Why? Because there are some genetic mutations that are more prone to cause arrhythmias. And we don't want anybody running around and passing out because of an arrhythmia. So definitely that's something to be discussed within the family, obviously, but we do recommend to screen first-degree relatives at the age of, teenage years, and then every 5 years with just an echocardiogram. For genetic testing, it's a little bit more complicated. Genetic testing in children has not been approved just yet. So again, when you meet, we in the Center of Excellence, we recommend actually meeting with a genetic counselor. Genetic testing, it is free, provided by some pharmaceutical companies, but it's so much more than a test. So it really impacts families in different ways. So we recommend genetic counselor that can explain more about the repercussions of having genetic testing. But that's for a screening. Also, just with an echocardiogram would suffice.
Great. Thank you all so much. This has been so wonderful, and we appreciate all your extra time answering these questions. I'll turn it back over to Lori.
Thank you. Yes, just to echo Vanessa's gratitude, we are so appreciative of you three's wonderful presentations and extra time to put this nice recording together for the community. And to our viewers, I just want to add, if you have any questions that about the information that was presented today, feel free to contact ARC. And we work closely with these wonderful providers, and we'll be happy to get an answer to your question and make sure that you get the information that you're looking for. Thank you all so much.
Thank you so much.
Thank you.
Thanks, everyone.